Good evening,
sir.
Shankar. How are
Good
you
evening,
guys?
sir. Good evening.
So we are going live in 15 seconds. Sir Subha will be starting and handing over the introduction to Dipankar sir, who will be introducing Vinita ma'am.
We are live.
Good evening all. Welcome to iFocus Online Lecture 270, the 11th in the Uvea Module. Today we have with us Dr. Vinita Rao from Nethralaya, Chennai to speak to us on VKH disease and sympathetic ophthalmia. May I request Dr. Dipankar Das to please introduce the speaker for today.
Thank you, Dr. Subha. Dr. Vinita Rao will be presenting the iFocus Online Lecture Series today. She's DNB from Nethralaya, Chennai, and was consultant at Ganapati Nethralaya, Maharashtra. And currently, she's senior consultant, Department of Uveitis at Nethralaya, Chennai. Published numerous papers in peer-reviewed journal, presented paper, and she has enormous contribution in VKH and sympathetic ophthalmia. Presented her paper at Rome, Iowa at Padova, the World Ophthalmology Congress at Brazil, and she's a founder member of Uveitis Society of India. Today, she will be presenting on VKH and the sympathetic ophthalmia. Both are a important stromal choroiditis that we are seeing in India and abroad. Dr. Vinita.
Thank you so much, Dipankar sir, for the introduction. Vinita ma'am, may I request you to share the slides?
Good evening to you all. Are you able to see my slides?
Yeah.
Yes, ma'am.
My thanks to the iFocus team, Professor Amod Gupta and Dr. Santosh Hunawar for inviting me to participate here. I'll be speaking on VKH disease and sympathetic ophthalmia. So VKH disease, as you may know, that it is the bilateral granulomatous panuveitis with extraocular manifestations involving the central nervous, auditory, and the integumentary system. It is a T lymphocyte-mediated autoimmune process against the choroidal melanocytes. The trigger is believed to be a cutaneous injury or a viral infection, which causes sensitization to the melanocytic antigens. Now, the exact target antigen is not known, but it is the possible candidates are believed to be a tyrosinase or a tyrosinase-related protein, which is found in the uveal tissue, inner ear, the meninges, and the integumentary system. 75 kDa protein and the S100 protein. Now, if you look at the epidemiology, there are a lot of cases, a lot of reports on the pattern of uveitis from different parts of India over the last several years, and the incidence of VKH reported in all of this is variable. The most recent study from Central India puts the incidence of VKH at around 11.7%. Japan sees roughly 800 new cases of VKH each year, but on the contrary, United States, the VKH is relatively rare, representing about 3 to 4% of the referrals to their tertiary care. And most of this is concentrated in their Hispanic and Native American population from North America. But if you look at the same thing in South America, in the Colombia region, which has a lot of Hispanic and Native population, VKH is not very predominant in that group. So there must be some genetic prevalence which is predisposing people to VKH. For example, the DRB104 allele is more prevalent in the East Asians who are more prone to VKH. Now, patients diagnosed with VKH are typically in the third or the fourth decade of life, but there are reports of it occurring as young as 3 years and as old as 78 years. Pediatric VKH cases can be challenging because they can be aggressive, long-standing, with complications like subretinal fibrosis. Older patients, typically more than 65 years of age, they have a propensity to develop optic disc hyperemia and choroidal detachments. Most of the reports say that women are more commonly affected than men. Now, descriptions of this disease dates back to the 12th century, but this disease is named after three physicians, Vo, Koyanagi, and Harada. Alfred Vo first described in 1906 the first case of VKH. This was a patient who had intraocular inflammation along with poliosis. In 1914, Koyanagi reported several more cases of VKH. And in 1918, Harada described posterior uveitis with exudative RD and CSF pleocytosis. Now, in 1929, there was a very interesting report from Koyanagi of 16 patients with bilateral chronic iridocyclitis with vitiligo, alopecia, poliosis, deafness, tinnitus. This was very interesting because it described the natural evolution of untreated VKH because treatment was not available at that time. It was only in 1950s that immunosuppressive therapy became available, and patients of VKH began to be treated with low doses of corticosteroids from late 1950s. In 1969, the first reports of high-dose corticosteroid for VKH started, and it was only in 1984 that pulse IV methylprednisolone for VKH came by. And it was after this that two patterns of the disease evolved. So the first pattern was where the disease could potentially resolve when the immunosuppressive therapy was vigorous and sufficient. And the second pattern was a sustained chronic evolution with progressive destruction of the ocular pigmentary structures and the integumentary structures due to inadequate treatment. Now, before the clinical features develop, the patients have prodromal features like headache, nausea, fever, vertigo, meningismus, and at this point, they usually present to the physician. Typically, this will last for a few hours or days, but sometimes even weeks. If they happen to come to the ophthalmologist at that time, a fundus examination may only show just internal limiting membrane folds. Now, this is the stage where you have subclinical ocular choroiditis and can be identified only by ICG or EDI-OCT. Or if you do a CSF tap, it can show CSF pleocytosis. After this, the obvious clinical signs come up. So by this time, the full thickness granulomas have come, and these cause delay in the choroidal flow and the choriocapillaris flow, causing ischemia to the RP, and this gives rise to the exudative retinal detachment, which can be focal, multifocal, or bullous, along with vitritis. Usually, this is bilateral, but at the time of presentation, it may clinically appear to be unilateral. The patients may also have these yellowish nodules in the periphery, the Dallen-Fuchs nodules, along with the exudative retinal detachment. Often we see optic disc hyperemia and edema. Conversely, if the patient comes much later, months or years later, and has not had adequate treatment, there may be features of chronic uveitis or recurrent uveitis, including features of hypopigmentation like the sunset glow fundus. You will see these peripheral hypopigmented small spots, the CRA spots, which are the scars of the Dallen-Fuchs nodules. You may see pigment migration and pigment clumping like this. Or rarely, you may see complications like subretinal gliosis, which is usually associated with a severe disease, bullous RD, and inadequate treatment. You may also see features of cutaneous hypopigmentation like vitiligo and poliosis and alopecia. One of the very important and easily available investigative tools is fluorescein angiography. Now, in the acute phase of the disease, when there is a lot of choroidal inflammation, the early venous phase shows delayed choroidal filling. And because of the choroidal granulomas, you see these hypofluorescent spots, which are actually better seen on the ICG. There are pinpoint leaks at the level of the RP, which progress to form this multilobular pooling. And you can see that each of these lobules is surrounded by a dark rim, which corresponds to the septae that we see in the subretinal fluid on OCT. Hot disc is seen in more than 90% of the cases in acute VKH and in around 66% of the chronic VKH, according to this paper. And this feature is very important in distinguishing VKH from the non-inflammatory causes of exudative retinal detachment. When you have a lot of pinpoint leaks, it gives the appearance of a starry sky. In the chronic stages, you can have a spotted hyper and hypofluorescence. Now, because of the exudative retinal detachment, there is damage to the RP cells. So if there is RP loss, you can have window defects from where the choroidal fluorescence comes through. Or if there is RP migration and clumping, there can be masking of the choroidal fluorescence, and this blockage gives rise to the hypofluorescence. Now, because VKH is a stromal disease, ICG is more useful than FFA, and ICG picks up these small hypofluorescent dark dots, which, as you can see, is much better delineated on ICG than FFA, and also seems to be more in number on the ICG than on the FFA. You can also see the hyperfluorescent fuzzy choroidal vessels, and in very severe cases, you may even find hypersenescence of the disc. In the late phases, you will see diffuse hyperfluorescence of the choroid. And if you look at these hyperfluorescent spots from the intermediate phase, some of them persist in the late phases. These are the full thickness granulomas, whereas some of them become isofluorescent in the late phases. These are the partial thickness granulomas. The other investigation is the swept source OCT and the EDI OCT, both of which are very important and useful investigations in VKH. It demonstrates these RP undulations and the choroidal thickening and the elongation of the outer nuclear layer. It is also very useful to demonstrate these subretinal septae, which are there in the dividing the subretinal fluid, and these septae occur because of the bacillary layer detachment, which is actually splitting of the photoreceptor outer segments, so that the outer myoids, ellipsoids, and the photoreceptor outer segments, they move backwards along with the RPE, and in the anterior structures move anteriorly with the external limiting membrane, and the intervening subretinal fluid appears turbid because of the broken fragments of the photoreceptors. You can also see the vitreous cells in the posterior vitreous. Now, all these features are very useful in distinguishing this from non-inflammatory causes of exudative retinal detachment, like, for example, a CSR. The EDI OCT is nothing but a modified acquisition on the SD OCT, which allows you to see the deeper structures better. If you have a situation like this where the VKH has just a posterior segment and a posterior full localized small exudative retinal detachment with very minimal inflammatory clinical signs, it may be very challenging to distinguish it from a CSR. So at this point, the OCT is very useful to demonstrate the clear vitreous, the smooth RP, and the uniform choroid. The reduction of choroidal thickness with treatment, as you see here, is also very useful to monitor the response to treatment. If you look at the autofluorescence, usually autofluorescence is very useful for diseases which affect the choriocapillaris and the RPE. But since VKH also affects these structures, autofluorescence is also useful in VKH. You can see the hyperautofluorescence in the active disease, which, if treated early and aggressively, returns to normal in remission. But untreated cases or in delayed treatment, there can be diffuse hyperautofluorescence, which resolves to patchy hypo and hyperautofluorescence. The swept source OCT angiography is very useful to study the vascularity of the retinal and the choroidal structures. The SSOCT demonstrates these full thickness granulomas, which corresponded very well to the hypofluorescent dark dots. These are areas of flow voids, which are the full thickness granulomas, and they're useful to differentiate it from other causes of RDs, exudative RD, which does not have this granulomatous changes. The HD-OCT-A is not as clear as the swept source, but you can still see the flow void areas more clearly in the choroid than in the more superficial layers. It is also very useful to monitor the response to treatment. As you can see here, the pre-treatment choroid shows many more flow void areas, which improves dramatically and reduces in number following treatment with corticosteroids. It is also very useful to diagnose and follow complications like the choroidal neovascular membrane. Now, if you look at the multimodal imaging of VKH, the gold standard still remains ICG and FFA to diagnose the disease. But on follow-up, you may choose to do non-invasive techniques like autofluorescence and the OCT. The advantage being that these are non-invasive, but the disadvantage is that you can see only a small portion of the fundus, unlike the ICG where you can see the entire fundus. In 2001, Professor Reed and co-authors, they published the revised diagnostic criteria for VKH disease. They classified VKH into complete, incomplete, and probable VKH. So complete VKH included the ocular features, either the early or the late features, along with the neurological and integumentary features, and the patient should not have had any history of ocular trauma. It should have been bilateral, and there should have been no other clinical evidence of any other diseases like syphilis or TB. The incomplete VKH had ocular features along with either neurological or the integumentary features, and the probable VKH had the ocular features alone. But there were some shortcomings in this criteria because it did not have a clear distinction between the initial onset and the chronic disease form. The revised diagnostic criteria said that the diffuse choroiditis should be imperative in the diagnosis of early ocular disease, but it did not include ICG or EDI-OCT, which can pick up the subclinical choroiditis. So some authors have proposed newer additions for being able to diagnose the early onset disease. So here, if you diagnose diffuse bilateral choroiditis by ICG or EDI-OCT, of course, the signs and symptoms should be less than 4 weeks for us to call it an early onset disease. And there should not be any findings compatible with chronic disease like a sunset glow fundus. Now, large number of cases can have remission or even cure before the depigmentation occurs or before the chronic disease sets in, if we can initiate early therapy in the window period, that is 2 to 3 weeks following the onset of the disease, and treat the patients with a combination of steroids and first-line non-steroidal immunosuppressives. Ideally, we should also monitor the subclinical choroiditis by ICGA so that you can titrate the treatment based on the persistence or the reappearance of the hypofluorescent dark dots. Because if you miss this window period, the disease goes into a chronic VKH, which is not prone to remission, and the patient can develop ocular complications like sunset glow fundus and subretinal gliosis, and extraocular complications like vitiligo and poliosis. Now, very often in many uveitis, we have seen that there is an overlap of clinical features, and so even in VKH also, there may be an overlap of features with other conditions. Besides that, the VKH affects the choroid, but the adjacent structures like the retina, the RP, the anteriorly, even up to the ciliary body, it can be affected. So there can be situations where the diagnosis can be challenging. So it's good to remember the differential diagnosis. We'll be discussing sympathetic ophthalmia next. I've already discussed central serous retinopathy and mentioned how we can differentiate it from VKH. Sarcoidosis has multiple presentations. So if it presents with nodules, dyskidema, choroidal granulomas, and exudative retinal detachment, it can be challenging to differentiate it from VKH. And you can differentiate it by demonstrating the periphlebitis on FFA or demonstrating the candle wax drippings, and even the clinical history or the laboratory investigations. Some anti-cancer medications can also have VKH-like pictures. Choroidal melanomas, especially those non-pigmented melanomas with subretinal pigmentary loss and serous RD, can resemble VKH disease, especially if they're small melanomas. But you can differentiate it based on the OCT and the ICG pictures. Infectious posterior uveitis, especially syphilis, is a good mimicker of many of the diseases. Tuberculosis, if it is associated with subretinal nodules and exudative retinal detachment, can also mimic VKH. Posterior scleritis can have exudative retinal detachment in the posterior pole. We can differentiate it by demonstrating the T sign. But there are some reports where even a massive VKH or a very severe form of the disease can secondarily also produce posterior scleritis. One of the very big challenges is to treat VKH when VKH coexists with central serous retinopathy, or when you're treating VKH, there is CSR develops in the other eye, like this patient who was being treated for VKH elsewhere and then developed CSR, as you can see here, and also had the choroidal thickening with the dilated choroidal vessels. So this is a very challenging situation to treat. Most of the reports on the long-term prognosis of VKH show a good visual outcome. The study by Massimo Accorenti of 38 patients with a long follow-up of almost 9 to 10 years showed that there was a significant improvement in the visual outcome. And they also found in their study that there was less relapses with IV methylprednisolone being given as the first-line treatment as against the oral corticosteroids, and less sunset glow fundus. This was not the same, it was not seen, the same results were not seen in Professor Reed's study from 2006. That was a multicenter study, and that study said that the route of administration of corticosteroids did not affect the final prognosis or the rate of complications. The Accorenti study also showed that the immunosuppressive therapy within the window period improves the final vision. But there was a long follow-up, so the number of cataracts and the glaucoma cases were more. So this was a patient of VKH who came to me with the bilateral total cataract, and we didn't know what we were dealing with. We did the ultrasound and careful follow-up. We put the patient on immunosuppressives and then took the patient up for surgery. And as I was doing the surgery itself, we could see the orange glow. And at the end of surgery, we could see the sunset glow fundus. But surprisingly, he regained good vision postoperatively. So it is important to remember that with good inflammation control, fecal emulsification, and in the bag IOL, you can get good postoperative results. Of course, the patient did have PCO and a bit of anterior capsular phimosis. Now, this is a large study of 352 eyes which underwent fecal emulsification, and they also found that the vision improved in more than 99% of their patients. And the reason for poor visual acuity in their patients was optic atrophy or complications like CNVM and subretinal fibrosis. Now let us come to sympathetic ophthalmia, which is a disease very closely related to VKH disease. And this person is closely related to sympathetic ophthalmia. He was injured at the age of 3 in his right eye when he was playing with a slender knife, and lost vision in both the eyes by the age of 5, possibly due to sympathetic ophthalmia. This is, of course, Louis Gray, and he went on to do great things despite his blindness and because of it also. So sympathetic ophthalmia is also a granulomatous inflammation occurring after penetrating injury involving the uveal tissue in one eye. And this penetrating injury is the most defining difference from VKH disease. The injured eye is the exciting eye and the fellow eye is the sympathetic eye. The onset is usually between 2 weeks to several years following the trauma or surgery, but recent reports say that it can be earlier also. But by and large, 80% of the cases occur within 3 months and 90% within the first year. Now, this is an important prospective surveillance study by Kilmartin co-authors from United Kingdom and Ireland, where they put the prevalence rate of sympathetic ophthalmia at 0.3 per 100,000 per year. The basic etiopathogenesis is a cell-mediated hypersensitivity to self-antigens. The study by Marak puts the incidence of sympathetic ophthalmia at 0.1% after intraocular surgery and 0.2 to 0.5% following penetrating injuries. There seems to be a bimodal peak, with the first peak being seen in childhood and young adults, probably because of the higher rate of injuries in them, and the second peak in the 6th decade, again probably because of the higher rate of intraocular surgeries in this age group. Now, despite better management of perforating injuries and despite the trend towards post-surgical sympathetic ophthalmia, still penetrating injuries form almost 75% of sympathetic ophthalmia from India in many reports. If you look at the post-traumatic and the post-surgical sympathetic ophthalmia, it is more commonly seen in males. Some because of the injury itself, occurring more commonly in males, and another reason could be because they seek medical treatment much more than the females. Theoretically, any perforating or penetrating injury of the globe with or without uveal prolapse has a risk of developing sympathetic ophthalmia. It can happen with perforating ulcers, scleral rupture, or following ocular surgeries. Even non-penetrating situations like severe contusions and lag lasers like cyclodestructions can give rise to sympathetic ophthalmia. Now, this was a case report of sympathetic ophthalmia following cyclocryo with histological correlation reported by Dr. Biswas, and he demonstrated the features of sympathetic ophthalmia and migration of the uveal pigments along the track of the cyclocryo. In fact, a couple of days back, he was relating this tale of how the journal, when he sent it to the journal, they asked for the glass slide of the histopathology to confirm the diagnosis before they accepted the paper for publication, because it was the first of its kind. In the past, recent past, there have been some thoughts about transconjunctival sutureless vitrectomy causing sympathetic ophthalmia, with many arguing that it could be a wound leak or a hypotony leading to uveal incarceration, or it could be the multiple vitreoretinal surgeries or an antecedent trauma leading to repeated handling of the uveal tissue leading to sympathetic ophthalmia. But subsequently, there have been studies which have shown that there is no difference in the incidence of sympathetic ophthalmia between sutureless vitrectomy and the sutured vitrectomy methods. Histopathologically, there is a diffuse thickening of the foroid, ciliary body, and iris in both the inciting eye and the sympathizing eye. There is infiltration with lymphocytes, epithelioid cells, and giant cells. Now, classically, sympathetic ophthalmia is not believed to affect the choriocapillaries, but this study by Dr. Rathinam showed the presence of lymphocytic infiltrations of the choriocapillaries in focal areas and areas of necrosis in their series. There is early infiltration with CD4 helper cells, followed by infiltration with CD8 suppressor cells. And interestingly, there's also a B cell predominance in the final stage of the disease, implying a possible B cell activation of the autoreactive T cells. There is also a genetic predisposition to this disease. The eye is a sequestered organ, and in the intact eye, the intraocular antigens bypass the local lymph nodes and circulate directly to the blood and the spleen. But in the injured eye, the pathogenesis is that the uveal tissue is exposed to the conjunctival lymphatics and the antigens move to the regional lymph nodes, resulting in a cell-mediated immune response. But there should be a concurrent presence of an infectious agent with an antigen to incite this immune response. There are many emerging theories of the immune involvement in the pathogenesis of sympathetic ophthalmia, and one of them says that there is a massive cleavage by the matrix metalloproteinases, which produce the immunodominant epitopes on the HLA class II antigens, which activates the autoreactive T cells. The CCL2 found in the granuloma of the sympathetic ophthalmia and the CXCL2, the stromal cell-derived factor, recruits the B cell, and there is B cell activation of the autoreactive T cells. This particular paper reported by Professor Amod, Professor Narsingh Rao, tells about the photoreceptor oxidative damage to the by these TNF alpha and the inducible nitric oxide synthase, which causes mitochondrial oxidative stress and photoreceptor apoptosis. This results in visual loss. So if we can block this by using the anti-TNF alpha agents, we can prevent the vision loss in sympathetic ophthalmia. The clinical features in sympathetic ophthalmia are very similar to what we see in VKH, in the acute disease having vitritis, exudative RD, and papillitis. You can see the Dahlen-Fuchs nodules in the periphery, the granulomatous uveitis, and most importantly, there is an exciting eye which is injured and inflamed. The extraocular findings are less common in VKH as compared to sympathetic ophthalmia, but we still can have CSF pleocytosis, sensory neural hearing disturbance, alopecia, poliosis. If you see the patients early on in the disease, sometimes you may just see the exudative RD in the posterior segment with very minimal clinical inflammation. This is a single center long-term study of 40 patients from North India, reported by Dr. Vishali Gupta and Professor Amod Gupta, where they analyzed 22 eyes which showed only posterior pole disease. This is an early form of the disease, having exudative retinal detachment, Dahlen-Fuchs nodules, papillitis, and even had peripapillary CNVM. Very often, the injured eye already you are not able to see the fundus, and the vitritis or cataract in the sympathizing eye makes it necessary for you to have the B-scan ultrasound, which can show the diffuse choroidal thickness and the shallow retinal detachment. The FFE features are almost similar to what you see in VKH with pinpoint leaks and late pooling. But there is one more pattern which has been reported in literature, a placoid APMPP-like pattern, which shows early hypofluorescence with the late staining and pooling of the dye. Choroidal vascularity index is a new tool which is upcoming and seems to be promising. The CVI index is regarded as a good tool for OCT biomarker for monitoring disease activity in diseases like VKH and sympathetic ophthalmia. It is regarded as a stable index and less influenced by physiological factors. The CVI increases during the active disease and reduces with corticosteroid treatment. This is the increase is because of the stasis of the choroidal blood flow, which occurs due to the inflammatory impedance. Dahlen-Fuchs nodules are a very significant part of VKH and sympathetic ophthalmia, but it's not a pathognomonic feature. The three types which have been described, one is the classical Dahlen-Fuchs nodules consisting of epithelial cells and lymphocytes covered by an intact dome of RPE. The second type is the focal hyperplasia and just an aggregation of the RPE cells. And the third is the degeneration of the overlying RPE, leading to disorganization of the Dahlen-Fuchs nodules and release of their contents into the subretinal space. This was a very beautifully documented report of the SD-OCT of Dahlen-Fuchs nodule and its progression. You can see at baseline there is a hyperreflective round-shaped nodule disrupting the RPE and penetrating the outer layers. At 2 weeks, you can see a partial regression of the lesion. And at 1 year, the final follow-up, you can see a further regression of the RPE, but there is atrophy of the RPE and scarring that you can see here. The best management of sympathetic ophthalmia is preventive with a prompt and clean wound closure. The primary enucleation is only useful in those cases which have no prognosis for useful vision, because the exciting eye may actually end up having better vision than the sympathizing eye. Early enucleation was the classic teaching within 2 weeks of the injury, but since there have been reports that sympathetic ophthalmia can occur as early as 5 days after the injury, this is also a little doubtful. Enucleation after the onset of sympathetic ophthalmia is controversial because very often it may have no benefit to the sympathizing eye. And last but not the least, the debate between whether it should be enucleation or evisceration. Once you've decided that the eyes have no visual potential and should go in for surgery, then the choice of procedure, whether it is enucleation or evisceration, depends upon the surgeon. Evisceration, of course, has a cosmetic advantage, but there's also a theoretical risk of sympathetic ophthalmia. The exact incidence of sympathetic ophthalmia following evisceration is a little difficult to estimate exactly because of the rarity of the disease. But if you look at the earlier studies, sympathetic ophthalmia did occur following evisceration, but with better sclerotomy technique to denature the proteins completely. So this has resulted in the more recent cases the reports to have no case of sympathetic ophthalmia, like this retrospective study which you see, where they had 491 primary eviscerations and 11 secondary eviscerations after the primary wound repair, which did not have any case of sympathetic ophthalmia. There is a preference for evisceration over enucleation currently. Historically, enucleation was preferred because you could put a larger ball implant and you could prevent the inophthalmos, but with better techniques now, that advantage is lost. As I'm sure many of the oculoplasty surgeons here will know better, the evisceration has a superior sotic motility. The preservation of the sclera for the ball implant is possible. There is lesser handling of the orbital tissues, so the bleeding is lesser and you have a better cosmesis. Now, coming to the treatment for both sympathetic ophthalmia and VKH, the corticosteroids are the mainstay of treatment, and in sympathetic ophthalmia, it is useful only once it has occurred. There is no role of prophylactic corticosteroids to prevent sympathetic ophthalmia from occurring. The first-line treatment is either IV methylprednisolone in severe cases or oral prednisolone. You give high doses for the first 2 to 3 months and evaluate it, and then taper it over the next 6 months to 1 year or even longer if you feel that the disease has not resolved completely. Along with that, we need to give immunosuppressive agents, which is the preferred agents are usually the antimetabolites. There was this report by Dr. Mamta Agarwal, who studied, it was a multi-center study, and one of the things that was reported in that was that both from North India and from South India, the preferred immunosuppressive which most people use is azathioprine. Also from Singapore, it is the same, but in UK they prefer to use the mycophenolate forfatin. But nobody prefers to use the cyclophosphamide or the other alkylating agents as the first-line immunosuppressive therapy. There are reports of adjunctive treatments with intraocular corticosteroids like triamcinolone, intravitreal corticosteroid implants, the Ozurdex, and slow-release devices like the fluocinolone implants. Of course, if there is CNVM, you may need to give anti-VEGF intravitreal injections. This was a study published by Dr. Sudha Ganesh about the management of refractory sympathetic ophthalmia with triple agents. This was 3 cases which they treated with oral prednisolone, azathioprine, and cyclosporin with good visual outcome. Recently, the biologics are an addition to our armamentarium, and focal reports have shown promising results with long-term remissions. As I mentioned earlier, the TNF-alpha is one of the agents causing the photoreceptor oxidative stress, giving rise to the apoptosis and vision loss. So anti-TNF agents like infliximab and adalimumab seem to have shown good results in refractory cases. Also, because B cells play a central role in the development and propagation of autoimmune disease, therefore depleting B cells with anti-CD20 monoclonal antibody rituximab in refractory VKH disease can be an informed choice for the patient. The complications of sympathetic ophthalmia are similar to VKH, cataract, glaucoma, subretinal fibrosis, optic atrophy. This was a report of cataract surgery in sympathetic ophthalmia reported by Dr. Sudha Ganesh, where the cataract surgery was performed in 17 sympathizing eyes and 1 exciting eye. And you can see that the postoperative visual acuity was very good. The mean follow-up in this report was 28.7 months. So they showed that with good inflammation control, phacoemulsification and in the back IOL, you can have good visual outcome. The main factors impairing the visual recovery was macular scar and optic atrophy in this series. There was also PCO noted in 14 eyes. So sympathetic ophthalmia can be controlled with aggressive stepwise approach with corticosteroids and immunosuppressive therapy. You can get prolonged drug-free remissions, but we require long-term prospective studies. A study by Professor Janet Davis and co-authors said that cataract, exudative retinal detachment, and optic atrophy are the factors associated with decreased vision in sympathetic ophthalmia. But with better healthcare facilities, early intervention, and superior wound repair techniques, and increased awareness, it has improved the prognosis of this disease. If you look at the Kilmartin study, visual prognosis is also good in that study, with 3/4 of their patients achieving a visual acuity of 6/12 or better at 1 year. The worst visual acuity in that study was 6/16. Another study on pediatric sympathetic ophthalmia reported by Dr. Partho of 20 patients. In that study also, the visual acuity of 6/12 was achieved in 70% of the patients, with 3 of the exciting eyes having good visual outcome. So both in sympathetic ophthalmia and in VKH disease, the good visual prognosis is related to prompt and adequate systemic immunosuppression. But the relapsing nature of the disease and complications remain the biggest challenge. Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am, for the very extensive talk and comprehensively covering both the topics of stromal choroiditis. And would Dr. Amod Gupta, sir, would you like to give any comments, sir, before we go on to the questions?
Vinita, it was an excellent talk on the VKH disease and sympathetic ophthalmitis. And I think you have covered practically all aspects. And the only thing I will like to add is that by and large, pathologically, both diseases are the same and clinically manifest the same, except for history of trauma. And I think this has been recognized for almost like 50 years or so, that VKH and sympathetic ophthalmia, they share so many common factors. And like what we had shown also, that because, textbooks always describe as a very, very, they will try to show those big, large mutton fat cataract precipitates, and they'll show those big synechiae, trying to paint a picture as if sympathetic ophthalmia is what we know as the chronic recurrent panuveitis that we see in VKH disease. But that chronic recurrent stage of VKH sympathetic ophthalmia is a late stage like what the VKH disease has. So the idea is to be able to recognize in the acute uveitic phase, and this acute uveitic phase is no different than what we see in VKH disease. These are the patients who come to the ophthalmologist in early stages, where they need to be recognized and treated as aggressively as we treat, and maybe a little more aggressively than we treat VKH disease. Because if we can treat them at that stage, I think we can cut down on the recurrences, we can cut down on the chororetinal atrophy, we can cut down on the complications. as you might have noted, Dr. Vinita was showing some of those patients who develop choroidal vascular membranes. So these are the complications that arise because we have allowed the inflammation to fester in the peripapillary choroid, and that's where the choroidal vascular membranes develop. So early recognition of sympathetic ophthalmia means that at least patients with trauma or those patients with vitreoretinal surgery where you have, chased them with repeated surgical procedures. So single vitreous surgery probably is not a great risk, but when you go on to chase that eye, and people have reported, with the increasing number of retinal surgeries, specifically vitreoretinal surgeries, that the incidence of sympathetic ophthalmia goes up. So now currently the vitreoretinal surgeries are the major factor rather than the cataract surgery or the glaucoma filtering surgery that we used to see. We used to see those iris inclusion or Shea's cautery and stuff like that. So we used to see sympathetic ophthalmia following those surgeries. These days it is because the vitreous surgery has become easy, you can keep on repeating that surgery, in the eye. So repeated surgeries is a major risk factor. Of course, the trauma remains the major factor, that too in the young people. So I think by and large, it is covered very well. And next we can see what we have the questions.
Yes, sir. So there are just two questions. How frequently do we perform a lumbar puncture CSF analysis in VKH cases? These questions are posted by the postgraduates on various forums on YouTube and Facebook. So this is for everyone to know. Ma'am, would you like to answer? How frequently do we perform lumbar puncture for CSF analysis?
Not frequently. I have not done at all because these patients rarely come to the ophthalmologist at that stage. They usually go to the physician with the prodromal features. So I have not really done any CSF.
It depends on what part of the world are you seeing these patients. For instance, Japanese would not label a case of VKH disease unless they have demonstrated, pigment in the melanocytes and the lymphocytic pleocytosis in the CSF. So is the Chinese. And mind you, these are the two countries, China and Japan, where they see the maximum number of VKH disease. So almost 40 years ago, when we started off, we used to do CSF. We used to ask neurologists to do that CSF taps for us. But subsequently, once we recognized, the acute VKH bilateral exudative retinal detachment is sine qua non of VKH disease. If you see this acute uveitis exudative, retinal detachment bilateral is VKH unless proved otherwise. So is the sunset glow fundus for a chronic recurrent uveitis or chronic recurrent VKH disease, where once you see them, you know the diagnosis. So you don't have to really do a CSF cytosis. And in the same breath, I would like to mention that ever since we have started managing these patients aggressively, starting with IV corticosteroids and followed by immunosuppressive therapy, we don't get to see the vitiligo or poliosis or alopecia the way we used to see long time back when we were very, very tentative in starting immunosuppressive therapy in these patients. So some of these have come down. So CSF tap, like in US, they will not do. And I don't think they do see many patients in Europe. And in India, we've done it 40 years ago, but no more. I don't think we do it as a routine.
Thank you, sir. Dr. Dipankar Das, would you like to add anything to this on VKH?
Yeah, what I agree to Professor Gupta sir about what he said is important, most important. But when they land up with neurologists, when they land up with neurologists, sometimes there may be a differential diagnosis. For example, say a lymphoma like characteristic changes can have a CNS involvement, and they see those cases for the differential diagnosis. For example, they see a lymphomatous cell there differentiating from the pleocytosis. Routinely, I have never done a CSF analysis for this.
Well, thank you, Dipankar, for pointing out the role of neurologists. Personally, I think we've had a series of at least 5 patients where the patients of VKH disease landed up with the neurologist with headache and symptoms of meningismus, and they were doing all kind of scans and not trying to figure out, and not having found anything. They sent those patients back to us. Back in the sense that they sent them to us. Okay, can you look at the eye and tell us what it is? Because they have papilledema and they have, because the problem is they can't see the inflammatory cells. So the mandate is that all neurologists who are looking at papilledema must get their eyes checked by ophthalmologists for any inflammatory activity, because they'll not be able to pick it up. Because all the time we are referring patients to neurologists, high time they also refer those patients back to ophthalmologists, when by mistake or by chance, because the headache and neck stiffness is a major symptom in early VKH disease, they end up there. So I have personally experience of at least 5 such patients, and I don't think that series got reported, but it was eye opener for the neurologists became good friends of us after that we also could do something for the patients. Otherwise, the physicians don't allow you to get near them, anytime.
Thank you, sir.
Thank you, sir. That's a very important point. We'll go to the next question. So, how early should we intervene in penetrating trauma to prevent development or decrease the risk of sympathetic ophthalmia? So, ma'am, would you like to answer this one? How early should we intervene in penetrating trauma cases to prevent sympathetic ophthalmia?
Like I said, preventive, like corticosteroids does not have a preventive role. You can only give it after the sympathetic ophthalmia has occurred. Preventive in the sense, yes, the prevention comes only from an adequate closure and a clean wound closure at the time of the injury. Apart from that, again, regarding the enucleation, which I discussed, the primary enucleation, we don't advise unless there is absolutely no visual prognosis in the exciting eye, because sometimes the exciting eye ends up being better than the sympathizing eye. And of course, again, the period of 2 weeks, within 2 weeks of injury, that also has, although that has been the classical teaching, even that is now reduced because the sympathetic ophthalmia can occur earlier than 2 weeks. And after sympathetic ophthalmia is developed, then of course it is quite controversial. So,
there is no delayed putting them together. Then anatomical integrity has to be restored, preferably immediately as you see the patient, not waiting for the morning, because the first 24 hours are the most crucial. That, if you can operate them, and these days a patient do reach within hours of the injury to the hospital, and the residents usually would be seeing them in the emergency services, and they would say, well, we'll see in the morning, it's late night. No, these must be repaired soon as the patient reports to the emergency service, because otherwise the longer you delay, the more the risk of sympathetic ophthalmia. It's a lifetime risk of going blind or being on immunosuppressive therapy. The stakes are very, very high in penetrating trauma.
Yes, sir. Dr. Rohan Chawla, would you like to add something to this on sympathetic ophthalmia?
So first of all, I would like to say a very comprehensive talk, Dr. Vinita. It was really nice. One point regarding VKH, like sir was saying about neurologists, I think I have seen misdiagnosis by neuro-ophthalmologists as well, who would have diagnosed it as papilledema, papillitis, and even sometimes doing an MRI, giving some mild hyperintensity, and they have again missed the cells and the inflammation. So like sir said, it is very important to look for the inflammation which will clinch your diagnosis. And regarding sympathetic ophthalmia, Again, it has already been mentioned, the prevention is best while the wound closure and the early wound closure and the more meticulous nature of the wound closure, that will help you. And like sir said, this is one disease where you may need a lifetime of immunosuppression, because some of these patients may never go into a total remission. And a large percentage of these land up with immunosuppressive therapy. But yes, if you treat them aggressively and with a very slow taper, you can manage them on an adequate dose where the side effects are also not too much and the patient also is in remission. So I think that is the goal. And I also remember one point, I think way back in 2002 or 2003, when there was a uveitis conference at PGI, I had seen sir and the Western authors were presenting very bad cases of VKH, and they were saying they were having horrible prognosis. And sir immediately said, no sir, we treat them very aggressively, and I think in our country, when we manage them well, many of the VKH patients do land up with a good visual prognosis in the long term. So that's what I learned there, and I think that's what the point is. Aggressive treatment.
That the outcome in our patients, the scarring, for instance, and pigmentary changes in the retina are much less in our population compared to what they described in the Hispanic population. By and large, Narsinga Rao's series, And he says, no matter what we do, they end up with extensive scarring and complications. But that's the kind of phenotype we have not seen in our population. I think more than 95% of our patients have 6/12 or better vision. And those few who have poor vision is because of the non-recognition of choroidal invesical membrane, which typically develops in the juxtapapillary area, and it takes long time to reach the fovea, but once it reaches, I have burned my finger, missed the diagnosis. And this happens when you have allowed the eye to develop sunset glow and choroidal atrophy, which is very prominent in the peripapillary choroid.
I think here again, now with the OCT angiography coming up, it's helping us because it may not be a very typical clinical membrane, no hemorrhage, and just a focal clump of pigment with little graying around it. And then if you just do an OCT, immediately it shows you the membrane.
Absolutely. I think if I have to say, the role of OCT angiography is far more important in locating these very early choroidal invesical membranes compared to the dark dots that we see, because OCT angiography as yet is not a good tool for studying the stromal choroiditis. As Vinita mentioned, these are the full thickness or partial thickness diffuse or choroidal granulomas that we have in these diseases. So OCT angiography as yet is not able to give us the choroidal stromal diseases. So whatever we're seeing is the compression of the choriocapillaries and flow deficit, on the OCT angiography. So only when it can be only as a kind of a indirect evidence of choroidal stromal disease, but it's got a limited role. ICG angiography, if affordable, is the greatest tool, because sometimes we get carried away by the fluorescein angiogram, because in fluorescein angiogram we are not able to appreciate the choroidal stromal disease as well as on ICG angiograph, and we tend to taper off corticosteroids sooner than later. And if you taper off corticosteroids sooner than the inflammation has subsided completely, which only ICG can show you that there is no more any dark dots seen in the choroid now when you start tapering your steroids. And then you can possibly have a long-term remission of the disease, or at least a good outcome, rather than entering into a chronic recurrent disease. So if you don't use ICG, you run the risk of having a chronic recurrent disease coming on sooner.
So we'll move on to the last question for the evening. Can you explain the reason for septae in subretinal space in a case of VKH? And Dr. Dipankar Das, would you like to take this one? What is the reason or
Yeah,
subretinal space?
That's a very important thing. If you see, when Vinita explained the BLD, the bacillary layer detachment, it is basically the intraretinal myojunction region where the septa is occur. But here is very important thing is that the retinal or subretinal, some hyperreflective spots you can see on those. This is been now described as one of the characteristics along with the changes that you see in the vitreous and the intraretinal. These septas we have seen pathologically also. These are basically intraretinal septas. Now the fluid accumulates. Okay. Now fluids, actually these are all these fluids are maybe a transudate because they are less proteinaceous substances that percolates from the choroidal layer that accumulates in the layer of the retina. What is important is that when Vinita has very nicely mentioned that choroidal vascular index, okay, what is important of this choroidal vascular index is that the fluid cavities when you start IVMP by 3 to 4 days, this shrinks down and choroidal vascular index lowered down. There's another component called choroidal stromal index. Okay, that is also important because the choroidal stromal index, it increases when we follow up the patient. So these are all the fluid changes that are being taken there. Now, very interestingly, these things, whether certain things are apart from the fluid, the Dehlen-Fuchs nodule, one thing I thought is very, very important, whether the Dehlen-Fuchs nodule are in the sympathetic ophthalmia or in the VKH or sarcoidosis, do they have a different characteristics? Okay, one important point I thought I'll raise here. Secondly, another important thing, sympathetic ophthalmia and VKH in children compared to the adult, whether they have a variable things, which is very, very important. And this has to be, if we can have a data out of it, we can get a new concept out of that. I think Gupta sir can add some point in this aspect.
No, I know that children tend to have much severer disease, at least the VKH disease is severer, and so is sympathetic ophthalmia. But exactly how much is the Dehlen-Fuchs nodules or those choroidal scars, which are typically seen in the inferior half of the globe, whether they are more than what we see in adults, because these patients are very few. If you have a lifetime experience, you will collect maybe 40 cases of sympathetic ophthalmia versus 400 cases of VKH disease. So it's very difficult, and VKH disease is not very common in children. We had the youngest child was the most difficult, which I saw at the age of 4 years. And when I wished to report that as the youngest child, the same month the case report appeared at AJO as the youngest child of the same age. So I said, makes no sense. But we have seen very difficult, and the child could be barely managed ambulatory vision, very difficult to control inflammation in these young children. So I'm sure the same is the case sympathetic ophthalmia. But usually sympathetic ophthalmia, they don't get those kind of injuries at the age of 4 or 5 years. It will be somewhere around 10, 12 adolescents who are more prone to these injuries.
Thank you, sir.
Thank you, sir. And thank you, Dr. Vinita, for the excellent presentation. Thank you, Dr. Amod Gupta. Thank you, Dr. Dipankar Das and Dr. Rohan Chawla for giving your inputs and your time to the iFocus program. And over to you, Subhab and Shefali. Subhab, you're muted.
You're muted, Subhab.
Yeah, sorry. Thank you so much, ma'am. Before we conclude for today, we have 2 small announcements to make from our side. The first is the much awaited physical iFocus is back for a 360-degree ophthalmology coverage for the postgraduate students from the February 26th to March 5th, and the registrations are open. And the second is all those students interested may register at www.meraevents.com. The next we meet on 11th of January, and the topic would be retinal vasculitis by Dr. Basu. A very good night, and thank you, everyone.
Thank you. Thank you, everybody.
Thank you, sir.
Thank you.
you.
Thank you, sir. Thank you,
Thank you.
everyone. Thank you.
Thank you.